what's up friends, this is Akshay Mansawala and welcome to this channel. And if you are new to this channel, please do like, share and subscribe. And the way you have shown love and affection to my previous videos, I hope you guys will also enjoy the video about the diarrhea. This unprecedented thought of discussing about the diarrhea emerged as soon as I came to know that diarrhea being one of the leading cause of under 5 mortality worldwide, that is 20%. So I'll be discussing about diarrhea. But before discussing about diarrhea, I'm going to give you some concept about how the complications going to happen in case of the diarrhea. Okay, so as you know that the first cell we can see, the first the structural first unit of life, that is cell, emerging into or just originated into the ocean, no? And the water of ocean is salty. And let's consider this is the first cell. Okay, so first cell, the cell has the cell is rich in potassium. Okay, whereas the salty water of the sea is rich in sodium. That's why sodium we consider as an extracellular, and potassium is an intracellular. This concept is going to help us when we discuss about the diarrhea and the complications of diarrhea. Intracellular. Okay. Before discussing about the concept definition of the diarrhea, let's talk about because the diarrhea is associated with the fluid abnormality. One of the complications of diarrhea, that is dehydration. So before dealing about the fluid, let's talk about the normal fluid inside our body. As you know, our body is composed of, our body holds 60% of our body. So fluid in our body. So fluid in our body is 60% of our body weight. In case of adult as well as in the pediatrics as well. Okay. So for example, in case of the adult, let us suppose an adult, well-built adult has 70 kg weight, right? Then the fluid in his body gonna be 60% of his weight, that is 70 into 500. That gonna be 42 liter. So in a well-built adult of 70 kg, he holds 42 liters of water. In the same way, in case of children, the fluid is 60% of the body weight of the fetus. Baby. Okay. So these fluids are divided into two compartments: intracellular and extracellular. So the fluid that is found inside the cell, that is 100 trillion cells, is intracellular, whereas the fluid outside the cell, that includes the plasma, blood plasma, interstitial fluids, and so on. Whereas this is whereas the extracellular fluid is 2/3. Okay, 2/3, and intracellular component is just not like this. So the fluid that is present inside the cell is intracellular, and apart from that, all are extracellular. There is plasma, interstitial volume, fluids, and intestinal fluids also is covered in the extracellular fluid. Okay. So the thing I'm going to discuss is like during diarrhea. Okay. Let's discuss about this quite a bit later once we will be dealing about the dehydration. Okay. So just keep this in mind that extracellular fluids are rich in sodium ions, whereas intracellular fluids are rich in potassium ions, because this will be beneficial. So when we will be discussing about the dehydrations and why dehydration takes place. Okay. Okay. So let's discuss about diarrhea. And we'll be discussing about this extracellular fluids concept quite weird in case of dehydration as a complication of diarrhea, because diarrhea leads to complications like dehydration and malnutrition, and malnutrition can lead to diarrhea, and diarrhea can lead into malnutrition. So let's talk about the definition. So change in consistency of stools, change in consistency of fluid, i.e. that is loose or watery, and frequency of stool in a day in a day, i.e. more than 3 times a day in a child with normal previous stool is known as diarrhea. So diarrhea is the change in consistency of stool, that is loose or watery, and the frequency of stool in a day, that is more than 3 times a day in a child with a normal previous stool. Okay, so this is a definition: more than 3 times, and the most consistent change in the consistency of the stool is the most consistent finding in case of the diarrhea. Okay, so this is the definition of the diarrhea. Then let's talk about the etiology. What are the etiology? What are the causative agents? Okay, so etiology. Usually diarrhea, viral infection are more than bacterial infection. So viruses are more responsible for the diarrhea than the bacteria, and the most common virus leading to diarrhea is rotavirus. Okay, most common virus leading to diarrhea is rotavirus. Okay, and followed by bacteria, that is most common bacteria leading to diarrhea is E. coli. The variant is enterotoxin E. coli. Okay. If you see in just a conceptual, like diarrhea is usually caused by virus. Okay, so there is no rationale of using antibiotics during the treatment of the diarrhea. So in a broad sense, if you say in a broad way, so management of diarrhea do not need antibiotics. In a view that the virus usually causes the diarrhea, that's why virus is not responding to the antibiotics. That's why it is no use of using antibiotics in case of the diarrhea. Okay. So another cause, if it is parasite, so parasite is the most common cause of diarrhea in immunocompromised or immunocompromised patients, or we can say child. So, and the parasite being Giardia. Okay, but if diarrhea or loose stool with blood, this is equivalent to dysentery. So if diarrhea or the loose stool is associated with the passage of blood in the stool, then this is called as a dysentery, and dysentery is usually caused by, most commonly caused by bacteria. Dysentery is most commonly caused by bacteria. Which bacteria? So bacteria here is Shigella flexneri. Shigella flexneri. Okay. Shigella flexneri. Listen. Diarrhea is most commonly caused by virus, but dysentery is most commonly caused by bacteria. The most common virus being responsible for diarrhea is rotavirus, whereas most common bacteria responsible for diarrhea is E. coli. Okay, but the most common bacteria leading to the dysentery is Shigella flexneri. Okay, guys. So this is etiology. Then after etiology, we will talk about the risk factors. So what are the risk factors responsible for the diarrhea? The risk factors. So risk factor is a personal hygiene. First one is the personal hygiene. Personal hygiene. Personal hygiene. Personal hygiene. Okay. So water supply. Water supply. Water supply. That is drinking water. Drinking water. Drinking water. And third way, like if you are using antibiotics for a prolonged time, you know, chronically, if you are using antibiotics for a long period of time, then use of antibiotic for a long period of time, it may also lead to the diarrhea. And at that moment, the organism responsible for the diarrhea is different. Okay, so in case of right here, note, if someone is using prolonged antibiotic therapy, okay, antibiotic therapy, then he or she is supposed to be suffering from diarrhea, and the causative agent here is in case of this is prolonged antibiotic therapy, in case of this is Clostridium difficile. So this is the organism responsible for causing diarrhea in case of the prolonged antibiotic used patient. Okay. So we can write here, because it is also caused by and diarrhea is also caused by antibiotic therapy. So the risk factor is prolonged antibiotics therapy. Okay. Prolonged antibiotic therapy. And another risk factor is malnutrition, and so on. Okay, so we discussed about the risk factor as well. Now let's also risk factor is okay. Let's talk about the clinical types of the diarrhea. Okay, so let's talk about clinical types of diarrhea. So talking about the clinical types of diarrhea, let's talk about this is clinical types of diarrhea. Clinical types of diarrhea. So there are 4 types of clinical types of diarrhea. Okay, 4 types. Let's discuss one by one. First one is acute watery diarrhea. Acute watery diarrhea. This last 4 cause is obviously infectious. So infectious and last less than 7 days. But it can last up to 14 days as well. But usually it lasts less than 7 days. Okay. So this is acute watery diarrhea. Second one is acute bloody diarrhea. Acute bloody diarrhea. So this is also known as dysentery. As soon as there is a passage of blood in the stool, diarrhea becomes dysentery. Okay, dysentery. Third one is persistent diarrhea. So persistent diarrhea etiology is also infectious. Dysentery is also infectious. This is also infectious, but it lasts more than 14 days or 2 weeks. More than 2 weeks. Okay. Persistent diarrhea, that is acute in onset, infectious in origin, and lasts more than 14 days. That is persistent diarrhea. The fourth one, last but not least, is the chronic diarrhea. So in chronic diarrhea, it is not infectious. Rather, this is non-infectious, and it is also lasting more than 14 days. But this is non-infectious. The main difference between the persistent and chronic diarrhea is one of them is infectious, whereas one is non-infectious. That is persistent diarrhea is infectious and chronic diarrhea is non-infectious. But both of them last for more than 14 days. Okay, and the cause for this is in chronic is due to malnutrition. Malnutrition, guys. This is due to malnutrition. The chronic diarrhea is usually caused because of the malnutrition, not because of the infection. Okay, and it lasts more than 14 days. So this is the clinical types of diarrhea. After this, we will be assessing whether because the most common complications encountered is during the case of the diarrhea in the children is the dehydration. So we will be assessing whether what sorts of the dehydrations have been present in the patients who is suffering from the diarrhea. Okay, so let's assess the dehydration. How we will be assessing the dehydration in case of the diarrhea patient. Okay, let me grab this. Okay, we'll be talking about this quite a bit later. Okay. Assessment of diarrhea. So next topic is assessment of diarrhea. So there are some parameters. Assessment of diarrhea. Whether this is so on the basis of the dehydration, so we can categorize the diarrhea complications as no dehydration, some dehydration, and what? Severe dehydration. Okay. So let's start. And here is no dehydration. The first one is no dehydration. Means there is no dehydration present. There is diarrhea, but dehydration has not been set yet. Okay. Then some dehydration, and this is severe dehydration. So we have talked about etiology, risk factor, clinical types, and now we are discussing about the assessment of dehydration. Then followed by we will be discussing about the management of diarrhea and then the composition of the ORS. Okay. So the parameter for assessing whether there is no dehydration, some dehydration, or severe dehydration is mental status. Okay. So first one is mental status. Whether allowed or not. So here it is. So there is no dehydration. That is why the patient is alert. Okay. Alert and active. And there is irritable or restlessness. Okay. And then in the severe dehydration, lethargic. Okay. And then we'll be approaching to the eye. So the approach of the dehydration will be seeing the patient's eyes, whether there is sunken eyes or not sunken. Okay. So in case of no dehydration, eye will be not sunken. Okay, because it is normal, right? So no, not sunken. So we can write eye is normal. But in case of some dehydration and severe dehydration, definitely there is dehydration. Then the eyes are supposed to be sunken, right? So we'll writing here sunken. Is also sunken. Okay. And then we'll be watching and observing whether there is tear or not. Okay. So tear is actually formed from the fluids, present in the blood vessels. So if there is less blood, or we can say the content of the fluid is a blood vessels is low, then definitely the formation of tear is going to be hampered. As a result of which we will be not encountering as much sufficient tears that is supposed to have be in the tear. Okay. So tear. And in case of tear, this is tear is present, we can say. Okay. And no tear, we can say, or dry. Here is also dry eye. Okay. And then mouth, we will be inspecting the mouth of the children. Okay. So we can either touch with a fresh finger as well. So we'll be touching, we'll be seeing whether the mouth is dry or not. Mouth is not dry. This is dry. Very dry. Okay. So dryness. And then we'll be checking whether there is thirst or not. Okay. As there is not, as there is no dehydration, the thirst is normal. yes, drink normally, drink normally, drink normally. Okay, and here is trust, trust is present. Okay, and in this case, child, because of severe dehydration, child can be lethargic, and child cannot drink water. Can't drink water. Can't drink water. Thirst is present but can't drink water. Okay. So then we'll be testing. This is like one parameter, another one parameter in a head area, and now we are discussing about the skin pinch test. Skin pinch test. So what are we supposed to do in skin pinch test? So we will make the patient to lie supine, in a supine position on the bed, okay, and we'll be observing. I will be doing the skin pinch test with the index and the thumb. We'll be just pinching the abdominal skin and try to pinch and leave it whether there is elastic recoil or not, and we'll be observing how much time whether it is taking to come back to its normal positions once before the pinching test is done. Okay, so we'll be on that basis we'll be assessing whether there is no hydration from dehydration and severe dehydration. Okay, so pinch test. So the skin once as soon as we pinch the skin in case of the hydration, it will abruptly come back to its normal position, and by taking less than 1 second. Okay, so it takes less than 1 second, less than 1 second. But in case of some dehydration, once you pinch the skin of the abdomen, and it will take quite time, okay, but less than 2 seconds to come to its normal position. So it takes less than 2 seconds to come to its normal position. But in case of severe dehydration, it will take more than 2 seconds to come to its normal position. So actually, or basically, it is a skin turgor test. Skin turgor test. Skin turgor test. Turgor test. Skin turgor test. And where do we observe this skin pinch test? In case of the abdominal skin. Let me say one thing here. As you have seen about the trajectory of the skin. So the trajectory of the skin is maintained by the fluid, water, and the fat. Okay. Turgidity of skin is maintained by two things. Okay, water, another is fat. So fat is normally in a case of diarrhea, but the thing is water. Because of the diarrhea, persistence losing or the increased losing of the stool in a loose water form, definitely there is going to be less fluids in the body, and as a result of which the water content will be decreased in the body, and once the water content or the factor responsible for the trajectory of the skin is decreased, no doubt the trajectory will decrease. That's why we are including such types of phenomena right here. That the skin pinch test in case of no dehydration will take less than 1 second, where in some condition less than 2 seconds. In case of the severe dehydration, it will take more than 2 seconds because the water content in the severe dehydration is extremely low, as a result of which the trajectory of the skin is not maintained, right? Okay. So this is the these are the tests. So on this basis, we will confirm whether the patient is either in a state of the no dehydration, some dehydration, or extreme dehydration, or the severe dehydration. On that very basis, we will be planning the management. So our next topic is the management of diarrhea. So under the management of diarrhea, if there is no dehydration, according to WHO, we are going to give the guidelines. Okay, according to WHO, we will give or treat the no dehydration with the plan A. Plan A. Okay, and in some dehydration, we will treat them with plan B. In case of severe dehydration, we will treat them with plan C. So, what are these plan A, B, and C? We will be discussing all these things one by one. Just bear with me. Okay, I will simplify this. Don't worry. Okay, guys. So in plan A, as you know, there is no dehydration. As I have promised you in earlier on the beginning of the session, that I will be discussing about doing the dehydrations, how these concepts are going to be utilized. So guys, let's suppose this is the body and okay. So guys, let's suppose this is GI tract. Okay, GI tract, and just imagine this is not the GI tract, but just imagine this is the GI tract, and so here is the blood vessels, right? So here is the blood vessels like this, blood vessels. Okay. So as you know, in case of diarrhea, whatever the content you are taking through the mouth, whatever the content you are taking from mouth, because of diarrhea, it is not going longer stay in the intestine or the GI tract as a result, and it will go and pass from the anus. This is very bad drawing, but let's just suppose this is anus, and from anus it will get back as a stool. Okay. So in diarrhea, the food do not stay because of the increased motility of the GI tract. The content will just pass from here and here. And instead of diarrhea, there is a severe or persistent loose watery diarrhea passes of the stool. So most of the fluid and the electrolyte will pass through the stool. Okay. So as you know, I have already mentioned that as this happens, the fluid is not being absorbed. The electrolyte and the nutrients are not going to be absorbed from this very GI tract. As a result, the fluid contents inside the blood vessels, it definitely will be decreased, right? So this is a blood vessel, and this is the cell. Sorry, let's back to the black one, the blue one. This is cell, okay? This is cell. So guys, just here, I have already mentioned you that how we learn whether the extracellular fluid is rich in sodium or the potassium. Just recall that the cell has been discovered, or the first cell has been found, or the originated in the ocean, and the water ocean is the salty, and the salt contains that is sodium. So sodium is the extracellular fluid, extracellular content, and whereas the cell is the intercellular, and it contains potassium. So here is our blood vessels, and blood vessels has a blood. Okay, so plasma and RBCs. Okay, guys. So what happens then, guys, in case of diarrhea? Since the level of the fluid is decreased because of the persistent loss of the fluid through the GI tract, there will be decreased volume of blood. Okay, because the volume of blood is maintained by that fluid as well, because that will be absorbed into the blood vessels, and that will be going to maintain the fluid of the blood as well, right? So because of that, what happens? The extracellular fluid, that is plasma, is going to reduce in case of the blood vessels. Because of that, if it is losing, then plasma contains sodium ions, because it is extracellular fluid rich in sodium. Once the plasma sodium value decreases, okay, so plasma sodium value decreases. So what will happen? As soon as the plasma sodium, or we can say here is also, this is also extracellular fluid. So the sodium here is also sodium extracellular. Interstitial fluid is also extracellular fluid, so it is rich in sodium. So sodium is already losing from the GI tract and water, right? So because of that, the content of the sodium and water in the blood vessels is going to be decreased, and this is going to increase the dehydration stage in the patients or the baby who are suffering from diarrhea, right? So the sodium, because sodium is decreased here, what is going to happen? As soon as the sodium is decreasing here, the osmolarity, we can say, of the extracellular fluid is going to be decreased, and as a result, the fluid from here is not going to come here. Okay, so just here. This is the cell, and this is the fluid. Isotonic, about isotonic, hypertonic. So if here is sodium ions, this sodium ion, if it is hypertonic. Let's suppose this is hypertonic. Hypertonic means more content of electrolyte than the solvent. Okay, so it will drag the water from the cell. If there is more sodium chloride in the extracellular fluid, this sodium ion will create or drag the water from the cell, and cell will undergo the shrinkage. Decreases in size. But if the sodium content inside the extracellular fluid is less, then the electrolyte that is present, that is potassium ions, will drag the water from the extracellular fluid into the cell, and cell will swell in a hypotonic solution. Okay, the same things happen here. the sodium keeps on losing from the GI tract, and the fluid is going to lose from the GI tract, and there will be the hypovolemic. Even the people, the baby or the patient will suffer from the hypovolemic shock. Okay. Okay. And with the passage of time, there will also decrease in the potassium content as well, because just listen. On the during the diarrhea, what happens? The secretory, the intestinal secretion that is alkaline in nature. Because of that, the intestinal secretion that is alkaline in nature, the bicarbonate ions are going to be also lose from the GI tract, as a result of which there will be metabolic acidosis. Right? There will be metabolic acidosis. So guys, just imagine here. GI tract first of all. So this is GI tract, and this is losing what? Water, electrolytes like sodium, on the very beginning, sodium, okay, and nutrients, okay. But followed by that, after some time, potassium will be also lost from the GI tract, and since the intestinal secretions are alkaline in nature, bicarbonate will be also lost. So as bicarbonate is lost from the GI tract, as bicarbonate ion is lost from GI tract, it will leads to metabolic acidosis. This metabolic acidosis, in order to compensate that metabolic acidosis, there will be respiratory compensation, and there will be Kussmaul breathing or respiration. So this is what, because of metabolic acidosis, there will be Kussmaul respiration, that is a fast and shallow breathing. Okay, so these are the presentations and the symptoms will be presenting in case of the diarrhea. Okay guys? Okay, so we're talking about the plants. This is how the pathophysiology takes place. Okay. So let's talk about the plan A on the no dehydration. Talking about the plan A, so there is a criteria. If the baby is less than 2 years, what are we supposed to do? We will give. Plan A is actually for the. Plan A is for the replacement of what? Ongoing losses. Okay, so there will be quite confusing terms right here, like the rehydration, the replacement, the maintenance. So let me explain quite about this. Let's suppose this is a drum, and this drum is full of water, right? And we have outlet here. Let's suppose here is a stopper, which is manually, to which we can manually open and close. Okay. So this is nothing but the no dehydration stage. No dehydration. This is synonymous with no dehydration stage. Why? Because as usually it is the bucket is full of water. The same thing in no dehydration. There is no in case of diarrhea with the no dehydration, there is no loss of the there is no deficit of the water, right? There is no deficit of water. In the same way, there is no deficit of water. But once let's suppose there is one episode of diarrhea. Let's suppose there is one episode of diarrhea, and this one is our GI tract. Let's suppose this is a GI tract, or we can say this is a drum of 100 ml, and for once we open for 1 second, it lost 5 ml water. Just imagine. This is a bucket filled with 100 ml water, and there is a stopper. We open the stopper for 1 second, and it in 1 second, and then close, and then there will loss of the 5 ml water. And if we add 5 ml water that has been lost because of the opening for 1 second, this is known as replacement. Replacement. Okay. So this is known as replacement. The same things I am going to explain right here. What is the replacement of one? Means let's suppose this is a diarrhea. One episode of diarrhea is losing 5 ml of water or the fluid or the stool from the body, or the water from the body. And then the same amount of water is replacing in order to replace the ongoing losses. Same thing happened here in a planning. In a 2 years, less than 2 years, ongoing loss, we will add how many ORS, that is 50 to 100 ml, 100 ml, 50 to 100 ml. Okay, less than 2 years. If there is one episode of stool, then we should have to add either from 50 to 100 ml, 50 to 100 ml in one episode. If there is next episode, then we will also add the next volume. Okay, and another one is 2 years to 10 years. 2 years to 10 years. In that case, we add 100 to 200 ml. Okay. In case of more than 10 years, in case of more than 10 years, we gonna add the libitum. The meaning of this is as much as he desire. He she desire. Okay. He she desire. If baby is more than 10 years, then we can add the fluid as much as we can give him fluid as much as his desire. But there is limit as well here. 500 ml per day. We can make for the baby less than 2 years, we can give him or 500 ml per day, and in this one 1000 ml per day max dose, and 2000 ml in more than 10 years baby, 2000 ml or 2 liter per day. Okay, so this is the replacement of ongoing losses. This is replacement of ongoing losses. In case of plan B, there is 3 modality of treatment. Okay, 3 modality. First one is let's exemplify the same case. Plan B, the way we pictorialize micropictorial diagram in order to understand the no dehydration. Now let's talk about the plan B plan. Okay, so this is swamp dehydration. Just I will make you know about this thing from the like the similar diagrammatic representation. Okay, so let's suppose this is a drum of the bucket. So this drum has initially 100 ml of fluid or the water, but now it has become 80 ml. Let's suppose it has become 80 ml after a few times. So if you encounter a baby or the patient in the state of swamp dehydration, then you will encounter directly at this level. Means her capacity of the blood or the fluid that he has already was 100 ml. Let's suppose 100 ml, but because of the diarrhea, he has undergone some dehydration, and in that case, you will encounter the patient at this various stage with these features, and there is 80 ml. Means already he has lost 20 ml. And he is presented at the swamp dehydration stage of diarrhea, and still he is passing stool. Episodically. Okay. So let's suppose there is a barrier like this that I have already discussed here. Next, one episode of diarrhea is gonna deliver or expel 5 ml, the way we had explained right here. So further 5 ml is going to decrease. So 80 minus 5 ml, that is 75 ml is going to remain here. So there was already dehydration. As well as the new episode of diarrhea, new episode of stool, passage that is 5 ml, is going to lose. So 20 ml already deficit. There was deficit of 20 ml, right? 20 ml deficit. And for the new episode of the diarrhea, leads to the loss of the 5 ml water. So if you compensate that 20 ml of deficit of water, that is rehydration. I.e., initially it was 100 ml, but because of dehydration in some dehydration stage, 20 ml was already lost. So 20 ml is dehydration, and further this 5 ml is lost. That is, if you manage this one, if you manage the already lost fluid, that is done by the rehydration, and if you manage the ongoing, that is ongoing. This one is ongoing. Still it is going. Okay, the episodes are going episodically. So if you replace the episodic loss of the fluids or the stool, fluid from the stool, then this is known as replacement. Replacement. Replacement of ongoing loss. Ongoing loss. Okay. Replacement of ongoing loss. So this is the concept here. Okay. Okay. So let's talk about this plant B, because I was discussing about the plant B. So in case of plant B, there is already dehydration. In case of no dehydration, there is no dehydration. That's why we did not rehydrate the patient. Just we compensate the losses that is encountering in case of the stool, frequency of the stool or the episode of the stools. Okay. So in the plan B, first of all, we will be what shall we be doing? First of all, rehydration. Okay, guys, rehydration. First of all, we will be doing rehydration because that is already the fluid deficit, and that should be overcome. Okay, by rehydrating the patient. Okay. So rehydration is done by 75 ml per kg within 4 hours. Within 4 hours, guys. Within 4 hours, we are supposed to rehydrate the some dehydration patient within 4 hours. Okay, and this patient should be hospitalized. This plan B is done in a hospital. Okay, health institution. This one is severe dehydration is also done in hospital. Management is also plan C is also done in hospital, but no dehydration stage can be managed at home. At home. Okay, at home. Let's come here. So 75 ml per kg within 4 hours. Within 4 hours, we are supposed to give this fluid. Okay. Okay. Then the second one is ongoing loss replacement. Ongoing loss replacement. H plan A. The way we did in a plan A, ongoing replacement is always done in this way. Okay. So now third one is maintenance dose or daily requirement. Maintenance or daily requirement of fluid. Daily requirement of fluid. So guys, in a daily requirement of fluid, it will it has one formula that we are supposed to do in a daily requirement. Okay, so the formula is it is given by the holiday Seger formula, which are supposed to be given within 24 hours. 24 hours. What is the formula? Let's get started. So formula is less than 10 kg. Sorry, 0 to 10 kg. 0 to 10 kg. We will be supplying the fluid that is 100 ml per kg. 100 ml per kg per day. And then 100 to 20, it is 1000 ml plus 50 ml per kg. Sorry. Okay, per kg above each kg. Sorry. Each kg above 10 kg. Okay, and greater than 20 kg, when we are supposed to give 1500 ml plus 20 ml per kg, each kg above 20 kg. So this is holiday Seger formula. Let's suppose let's take an example. Okay, guys. Let's take an example. So there is 25 kg baby in some dehydration stage. How will you manage? How will you calculate this maintenance dose or the daily requirement fluid? So as you know, for 25 has 10 plus 10 plus 5. We get it. For the first 10 kg, we have written as for the formula 100 ml per kg. So 100 ml So this is kg, this is kg, this is kg. Okay, 100 ml into 10, that is 1000 ml. Okay, and this is for next 10. That is we have written formula is 100,000 plus 50 into per kg above 10. So above 10, what is the per kg above 10? So in case of 10 is 15. So we are not going to write here 15. Next for the next above 10 kg. Okay. So we will be writing here 10 ml. So this is gonna be So let's write this in this way. That is the direct way to calculate this one. Okay. 20 ml per kg, so is 100 ml and 20 into 4 kg 5. Okay. So you can directly use this formula, last one directly. Okay. Since the weight is greater than 20, so we have the formula. If the weight is more than 20, then we will be using this formula, right? So 15 for 25 kg baby, fluid will be 1500 ml plus 20 ml. So above 20 kg, each kg has 20 ml. Then 5 kg is above the 20, so into 5. Okay. So this is gonna give you 1500 ml plus this is 100, and this is gonna be 1600 ml of fluid is required daily to that kg. Okay. So this is horizontal second formula. Okay. So now let's have a plan C. This is the last one, and then we'll be talking about the words component, and this will be finished. Okay. Let's bear with me. So let me rub this one. Okay. So let's have the plan C. Okay. So in plan C, so this is given orally, right? Orally. This is given orally because ORS is present here. Orally. In plan C, we give IV fluid. We give IV fluid, and the preferred fluid is Ringer's lactate, RL greater than NS, with 5% dextrose solution. With 5% dextrose. Okay. Then the fluid we give is 100 ml. Sorry, for the rehydration. First one, rehydration. For rehydration, we give 100 ml per kg for 6 hours. In the plan C, the rehydration dose is 100 ml per kg for 6 hours. Okay. So this is divided in a divided form. It is for less than 1 year. For less than 1 year, 30 ml, 70 ml in a two divided form. Okay, 30 ml in 1 hour, 30 ml in 1 hour, and 70 ml in next 5 hours, because the total duration is 6 hours. Okay, so 5 hours. Okay, but if the baby is greater than 1 year, then 30 ml is given in 1/2 hour, and 70 ml is given in 5. So 2 by 1/2 hour. That is 2.5 hour. 2.5 hour. This is 1.5 hour. Okay, so this is a rehydration dose. And in a similar way, ongoing loss, that is replacement is plan A, and maintenance for daily requirement fluid is holiday Seger formula. Okay. So this is how we are going to manage the diarrhea, dehydrations in case of the diarrhea. Okay. So this is one of the complications. This is one complication that is managing, that is dehydration. Okay. With these fluids, we also provide zinc. So there is zinc supplementation. So what is the function of zinc? Okay, zinc supplementation. Zinc supplementation. Zinc supplementation. Okay. So what is supposed to give the zinc in case of this one? So what happens, guys? Zinc has the three functions. So that we supply the zinc. First of all, it helps in epithelialization of the gut. Epithelialization of gut, GIT. Okay. And another is prevent future recurrence of diarrhea, and prevent the future recurrence of diarrhea, and prevent the worsening of diarrhea as well. Okay. And what is the dose? So we have divided the dose into two forms. Less than 6 month baby, 6 month baby, we give 10 milligram for 14 days, and greater than 6 month babies, we give 20 milligram for 14 days. That is, the duration of zinc supplementation is irrespective of the age. Okay. Okay, guys. So this is about the zinc supplementation. And another thing I'm going to talk is ORS, components of ORS. Okay. So let's write here components of ORS. So components of ORS is, first one is sodium with osmolarity. And the one thing I have to mention here, guys, the latest that we are supplying or giving or feeding the ORS is WHO low osmolarity ORS, and this is recommended from 2004, guys, most one, because before 2004 a standard WHO ORS was using, which had the osmolarity of 311 millimole per liter, which was not effective, and there were so many complications with that. That's why that was obscured now. And from 2004, WHO has revised, and the low osmolarity ORS has been given, which has a osmolarity of 245 millimole per liter. Okay, so this is osmolarity. So sodium has osmolarity of 75, and chloride has osmolarity of 75. No. Glucose. So glucose has osmolarity of 75, and chloride has 65, and then potassium has 20, and citrate has osmolarity of 10. And if you calculate this is going to be 245 millimole per liter. So you can notice here, guys, sodium and glucose has the same osmolarity, or given in a 1:1 ratio. Why? The answer is SGLT, that is present in the intestine. That the recent result is of sodium glucose co-transporter. This helps to transport one molecule of glucose and sodium together. That's why we give sodium and glucose in the same osmolarity, same ratio. Okay. And apart from this, there is not only that we have only this is a symptomatic approachment. We are approaching the symptoms. That is also symptom. Dehydration is also symptom. So dehydration is dehydration is sign. We are managing the sign. Okay. So we are also we also manage the symptoms as well. In case of diarrhea, symptomatic approachment is also done. And for the definitive treatment, during the acute phase of diarrhea, the use of antibiotics, anti-motility, and anti-secretory agents has no role. But let's know something about this as well. So in case of diarrhea, okay. In case of diarrhea, diarrhea. If you are using the drug therapy, so drug is, let's suppose we are giving this plan A, we are doing this plan A rehabilitation, okay? So we are providing the fluid to the baby, ORS to the baby in a very frequent way, in a 1 to 2 minutes, with a teaspoon. If the baby is less than 6 months, we can say, or the 2 years, okay? And let's suppose the baby starts vomiting. So if baby starts vomiting, then we'll wait for 10 minutes, and then we'll provide with a teaspoon in a very slow manner, okay? So initially we are giving in a 1 to 2 minutes, but now we are going to give in a 2 to 3 minutes by waiting 10 minutes after the vomiting, okay? Okay, guys. So after that, I'm going to talk about, okay, so drugs. So what are the drugs we give you? So motility, anti-secretory, probiotics. So these are the drugs we give. Okay. So anti-motility drugs are loperamide. So loperamide leads to if you provide this in case of the if you provide anti-motility drugs, guys, listen very carefully. If you provide loperamide, anti-motility drugs in case of the acute diarrhea, and if it's infectious, then just imagine that, guys, the bacteria or the organism that is getting much more time in the intestine. That is why it gets proliferated and multiply and causes a degenerate and it becomes a graveyard for the situation. Okay, so we do not usually provide loperamide in case of the acute diarrhea. So loperamide is little bit contraindicated, you can say. So loperamide, okay, and it causes the abdominal distension. So this is one of the drugs that is leads to abdominal distension or swelling, you can say. Anti-secretory drugs like resicadotril. This inhibits the intestine enkephalin, okay? Intestine enkephalin, anti-secretory. And probiotics like lactobacillus rhamnosus. So these are the drugs we use. Okay. So guys, I think this is enough for today. Okay. Intestine, enkephalin, anything I'm like, okay. So if it is diarrhea, if it is dysentery, then we will treat them with the third generation cephalosporins. Example is most commonly we use is cefizime drug, and also we can use another drugs as well, antibiotics as well. So we treat this with this cephalosporin. And if it is parasitic, in case of parasitics, we give metronidazole. Okay. And in case of diarrhea, we give drugs like the ampicillins. Okay, ampicillins and gentamicin. So I think this is enough for today, guys. So thank you so much, guys, for watching this video and being through the video. And I hope you like this video. If you are new to this channel, please like, share, and subscribe to this channel. And thank you so much for being here.